Good evening, ladies and gentlemen. First of all, I want to thank the organizer for inviting me to talk about this topic, the Tremor Approach. And I want specifically to thank Dr. Suhai. Thank you, Dr. Suhai. So here are my disclosures. Now, let's come back to some basic definitions. But first of all, I'm going to launch some videos. I hope it will work. Yes. So tremor is between 2 to 6% of outpatients who visit a neurologist. So it's very frequent. And the most frequent abnormal involuntary movement in neurology is tremor in neurology clinical practice. So tremor is a non-oscillatory and more specifically sinusoidal, typically rhythmic and regular movement that affects one or more body parts. This is an old definition by Desjardins in 1914. And it's produced by rhythmic, alternating or simultaneous contractions of agonist and antagonist muscles. What are the differential diagnosis of tremor? So most of other abnormal involuntary movements are easily differentiated, like chorea or tics or so on. But some other abnormal involuntary movements can raise some issues. For example, the clonus, which is triggered by a stretch reflex, which is very frequently associated with important pyramidal signs. You have got also the myoclonus, that can be rhythmic or pseudorhythmic, but conversely to the tremor, which is sinusoidal, the myoclonus is squared when it's rhythmic. And there is an interesting differential diagnosis between essential tremor and cortical tremor, which is actually family cortical myoclonus. Epilepsia partialis continua can also be an issue, but EEG makes easily the difference. And finally, what is really very frequent is isolated tremor. Going to start again here. And for example, head isolated tremor, like in this video, where you don't know exactly if this tremor is related to essential tremor or dystonic tremor. And dystonia is completely different from tremor. And you can just observe here that there is a very mild right tilt of the head that suggests that it is rather a dystonic tremor than an essential tremor. But we will come back to this distinguishing later on. So this tremor approach actually is going to mainly relies in this topic on the new classification of tremor, as I put new in commas, in quotes, because it's not that new, but new anyway, because it has been published in 2018 by the Movement Disorders Task Force on Tremor. And this is really a very, very interesting and completely new classification of tremor. And I'm going to mostly talk about this classification. So in this classification, you can see that there is an axis 1, which is clinical features, and an axis 2, etiology. And the axis 1 is shared in historical features, tremor characteristics, associated signs, and additional laboratory tests. And for example, in historical features, you have the age at onset, the temporal onset and evolution, the past medical histories, the family history, the alcohol and drug sensitivity. In tremor characteristic, you have the body distribution, the activation conditions, the tremor frequency, and here you have some associated signs which are very important to look at, signs of systemic illness, neurologic signs, soft signs. Soft signs, it means very subtle, very refined neurologic signs. And you have also the additional laboratory tests that can help. Age at onset has been divided in infancy, childhood, adolescence, early adulthood. It's important, but not that important. And body distribution, conversely, is very, very important because the definitions are very crucial because it's going to help when we're going to move to the tremor syndromes. So body distribution. So the tremor can be focal. Only one body region is affected, such as voice, head, jaw, one limb. The tremor can be segmental when two or more contiguous body parts in the upper or lower body are affected, for example, head and arm, or two arms or two legs. You got also the possibility to have an hemitremor when one side of the body is affected. And of course, it can also be generalized. And by definition, tremor in the lower limbs or trunk during standing is called orthostatic tremor. So now, what about the activation condition? This is also a crucial part of the clinical examination and of the clinical classification in syndromes. Activation of tremor. So there are sometimes some confusion between action tremor, is action kinetic and postural, is action only kinetic. Definitely there is rest tremor and there is, sorry, action tremors that can be divided in kinetic tremor, postural tremor, and isometric tremor. Isometric tremor is a tremor of the fist when you do that. So postural tremor can be position independent or position dependent. It's very important, specifically in dystonia tremor. And kinetic tremor can be divided in simple kinetic tremor. For example, when you do the nose finger maneuver, it can be an essential tremor. An essential tremor, intention tremor, sorry. Intention tremor is when you have a tremor during the maneuver, the finger nose maneuver, and when you approach the goal, which is the nose, the tremor increase in amplitude. And you have also the task-specific kinetic tremor. For example, when you brush your teeth, you have tremor. When you shave, you don't have any tremor. Additional tests can also be helpful. As I told you, some electrophysiological tests or structural imaging or receptor imaging like DAT scan or something like that. And also blood tests, serum and tissue markers can be helpful not only for delineating the axis 1 syndromes, but also for elucidating the axis 2, the etiologies. So finally, tremor frequency is not that helpful, finally, because most of the tremor associated with an organic condition are between 4 and 8 to 10 hertz, but only very unusual tremor like tremor, autostatic primary tremor, it's at roughly 13 hertz. And for myarrhythmia, we're going to talk about myarrhythmia. It's a tremor, very, very slow tremor, roughly 1 or 2 hertz. And also palatal tremor is very slow as well. But most tremor are between 4 and 10 hertz. And honestly, the frequency is not very helpful to find first of all, the clinical syndrome and then the etiology. So here are the tremor syndromes. So we're going to review each part of this classification. So as you can see, some axis 1 signs and symptoms will coexist so commonly that a specific clinical syndrome is suggested. A syndrome consisting only of tremor is called an isolated tremor syndrome, very important definition. A syndrome consisting of tremor and other systemic or neurological signs is called a combined tremor syndrome. And syndromes are defined for the purpose of facilitating a search for specific etiologies in axis 2. And again, what is important is a tremor syndrome may have multiple etiologies, of course. This approach to tremor classification provides ample flexibility for elucidating new syndromes or phenotypes without etiological assumption. And this is quite important in particular for isolated tremor of unknown etiology. So the tremor syndrome actually are a very important step to help find the cause. And here is a non-exhaustive list of all the different etiological causes of tremor. So first of all, let's review the first part of this tremor syndrome classification, which is isolated segmental action rest tremor syndrome. And of course, we're going to find the essential tremor syndrome, which is defined by isolated tremor syndrome of bilateral upper limb action tremor. at least 3 years duration with or without tremor in other locations, for example, head, voice, or lower limbs, with absence of other neurological signs such as dystonia, ataxia, or Parkinsonism. So this essential tremor syndrome has multiple etiologies. Frequently, you find a family history, and small doses of alcohol may improve the tremor. And some studies, however, have included patients with neurological signs of uncertain relationship to tremor, which is called soft neurological signs, such as mild memory impairment, impaired tandem gait, subtle body posturing that could suggest dystonia. And that's the reason why, even though there is no consensus on which of these additional signs are acceptable within the definition of essential tremor, in clinical practice, when you have these soft signs in addition to the essential tremor, it's proposed to label these cases with soft sign as essential tremor plus syndrome. So this is important. And here are the exclusion criteria for essential tremor and essential tremor plus syndromes. Isolated focal tremors with voice and head, autostatic tremor with a frequency above 12 hertz, task and position-specific tremors, and sudden onset and stepwise deterioration. So here I'm going to go quick on this because this is not the purpose of the talk, but here is all the treatments you can use in essential tremor, and with the drugs, of course, with also botulinum toxin, not only in head tremor, but also in hands tremor. We have published a case study last year on this topic, and of course, the brain stimulation. So now we have also other isolated segmental action tremor syndrome with isolated segmental postural or kinetic tremor syndromes commonly involve the upper limbs, but also may involve the head, voice, tongue, and face. So the upper limb are not mandatory, contrary to the essential tremor, and there is no criteria of duration, not like in essential tremor definition, with at least 3 years of evolution. So many patients with this syndrome ultimately fulfill the criteria for essential tremor. And the other, you have either some patients who later develop focal or segmental dystonia that is idiopathic or attributed to genetic abnormalities such as DYT24. And age of onset and family history may also help to identify these cases. And other patients suffer from enhanced physiological tremor. Enhanced physiological tremor is a very common bilateral upper limb action tremor. So enhancement of the normal reflex loop and 8 to 12 Hz central neurologic oscillation of physiological tremor by a variety of reversible conditions. So anxiety, fatigue, hyperthyroidism, and different drugs can give this kind of tremor. And what is important is that it's potentially reversible if the cause of the tremor is eliminated. And this is a very frequent common diagnosis, differential diagnosis with essential tremor, but the duration of enhanced physiological tremor is usually far less than 3 years. And electrophysiological studies are helpful in distinguishing mild essential tremor from this enhanced physiological tremor. Now, let's move to the second big part of this syndromic classification with the isolated focal tremor syndromes affecting head and voice. So an isolated voice tremor is a visible or audible tremor of the vocal apparatus. There are no signs of dystonia in the vocal apparatus and no tremor, dystonia, or the neurological signs elsewhere. And you can have some cases with hyperabduction or hyperadduction of the vocal cord, as observed in laryngeal dystonia or with dystonia in other body part of body, which will be classified as dystonic voice tremor. And for this part, we will see the section dystonic tremor syndrome. Voice tremor can be observed in DYT6 and DYT24 without evidence of clinical dystonia, I mean abnormal posture. And voice tremor in essential tremor occurs by definition in combination with hand tremor. Regarding isolated head tremor, this is a shaking of head with a yes, yes, a no, no, a variable pattern of head movements. It's very common in the context of essential tremor. It's also a very common manifestation of tremulous dystonia, and the relationship between isolated head tremor and focal tremulous cervical dystonia is still a topic of ongoing controversy. You can also find in this section other rare focal tremors that may occur in the absence of other neurological signs, like isolated jaw tremors, the hereditary geniospasm, or the Rabic syndrome, for example. So in isolated focal tremor syndrome, you find also a second entity, which is essential palatal tremor, which is characterized by rhythmic movement of the soft palate at 0.5 to 5 hertz. There is an ear click most of the time due to rhythmic contraction of the tensor veli palatini. You have also other throat muscles that can be involved. You have, and conversely, no other neurological abnormalities. I mean, it means air extremity or eye muscles are not involved. And the MRI of the inferior olives in the medulla oblongata is completely normal. The etiology is unknown, even though some somatophone, functional origin has been described. Now let's move to the second part of this tremor syndrome classification with isolated task and position specific tremor. So this kind of tremors occur during specifically a task or a posture. It's usually focal. Is it a variant of dystonia? Is it an overuse syndrome or simply a unique isolated tremor syndrome? It's still debated. It should be distinguished from similar syndromes that occur in combination with other neurological signs, such as dystonia, for example, writer's cramp, Parkinsonism, for example, young onset Parkinson's disease with dystonia. And here you can see a video of primary writing tremor, the most common form of task-specific tremor that occurs only when writing or attempting to write before writing, when the patient holds the pen. So you have also task-specific tremors of the hand or mouth, also that can occur in musicians and sportsmen. Now, let's move to the fourth big category of tremor syndrome, which is orthostatic tremors. So you have the primary orthostatic tremor, which is generalized high frequency, 13 to 18 hertz, isolated tremor syndrome that only occurs when standing and goes away when the patient walks. The confirmation of the tremor frequency is needed, typically with an electromyography. And this primary orthostatic tremor may be palpable but not visible, and the diagnosis really needs confirmation of the electrophysiological data. What is also interesting that is an audible rhythm called the helicopter sign may be detected by auscultating the lower limb muscles or by listening to electromyogram. And again, orthostatic tremor with the electrophysiological properties of primary orthostatic tremor can occur in combination with other neurological conditions like dementia, Parkinson's disease, or spinocerebellar ataxia. And in this case, it should be labeled as primary orthostatic tremor plus. You have also a variant of this tremor during standing, but with a lower frequency than 13 Hertz. It's called slow orthostatic tremor, or tremor in autostatism, or pseudo orthostatic tremor. Its frequency associated with other neurological signs, like various forms of Parkinsonism or dystonia. And this is a combined tremor syndrome that should be classified, and that is classified in tremor syndromes with prominent additional sign, which is the fifth category of tremor syndrome. Now let's move to tremor syndromes with prominent additional signs. So first of all, dystonic tremor syndrome are tremor syndromes combining tremor and dystonia as the leading neurological signs, and different syndromes are separated on clinical grounds. So what is important is that the tremor is in a body part affected by dystonia. Otherwise, it's a little bit different. It's just a tremor associated with dystonia when the tremor and dystonia are not in the same body part. You can have a tremorous cervical dystonia, for example, a dystonic head tremor, or you can have a segmental tremulous dystonia affecting the head and upper limb. What is really helpful is sensory tricks, the gest antagonists that can be helpful in separating dystonic tremor from essential tremor. Dystonic tremor may also be relieved by allowing the abnormal dystonic posture to develop without resistance. This is called the null point. And conversely, dystonic tremor can be exacerbated if you attempt to maintain certain posture in different side of the abnormal posture, for example. To move. Now you have also another tremor syndrome with prominent additional sign, which is a tremor combined with Parkinsonism, and the additional signs are bradykinesia and rigidity, but also the gait disorder. So it's usually asymmetric and unilateral in onset, as you know, for this rest tremor. Rest tremor in PDCs are greatly subsided when the muscles are activated voluntarily to execute a posture or movement. And this phenomenon may be followed by delayed re-emergence of tremor when a new limb posture is sustained. This is called re-emergent tremor. And these features clearly can be helpful in separating Parkinson rest tremor from the rest tremor you can sometimes observe in essential tremor plus syndrome. So also rest syndrome is very less common in other Parkinsonian conditions, such as atypical Parkinsonism. Now let's move to another type of tremor syndrome with prominent additional sign, which is first of all the intention tremor syndrome, which is an intention tremor, so a kinetic tremor with which exacerbates when at the goal approach, with or without other localizing sign. And usually this intention tremor is an intention tremor, is consecutive to the lesion in the cerebrothalamic pathway. And of course, you can find some cerebral syndrome associated, and it's caused by the very wide range of disorders, and syndromic association help in the differential diagnosis for this kind of patient. In this intention tremor, you can, for example, find the FXTAS syndrome of the X-fragile premutation. Horse tremor is a very interesting entity that is due to a very slow tremor, essential intention tremor, but also with a rest component. Why is there a rest component? Because this is a tremor related to a lesion in the brainstem, in the vicinity of the red nucleus, but also of the substantia nigra. That explains the rest component. It was formerly called rubral tremor or midbrain tremor, and it usually happens with other localizing signs. And when you get some dystonia and abnormal proprioceptions, it means the lesion frequently involves the thalamus. As here, I'd like to show you. Here you can see the rest component on this video. Now, myarrhythmia. Myarrhythmia is very, very rare rhythmic movements disorders. It's completely, it has to be distinguished from palatal tremor, rhythmic skeletal myoclonus, and epilepsia partialis continua. It's a very, very slow tremor, sometimes 0.5 or 1 hertz, as you can see here. It's caused by pathology in the brainstem or cerebellum, and it's usually associated with other brainstem or cerebral signs. And one typical etiology of this tremor is Whipple disease, and this patient presents with a Whipple disease. Oops. And finally, in this category of tremor syndrome with prominent additional signs, we can also find the neuropathy as associated tremor. So you observe this kind of tremor mostly with demyelinating neuropathies. You can observe it specifically in gammopathy-induced neuropathies, but also in the phase of recovery of Guillain-Barré syndrome. It's an action tremor, and you have, of course, signs of neuropathy. Now, you have always in the classification of the tremor syndrome with prominent additional sign, you have symptomatic palatal tremor. So symptomatic palatal tremor, you have also the palatal tremor. Most of the time you don't have any ear click. And you have also some other muscles than levator veli palatini that can be involved, such as eye movements or face muscles or neck muscles or trunk muscles. And it's typically combined with ataxia. Here you got the palatal tremor, and here you got a focus on, here you got some tremor in the neck muscles. So in this tremor, you have abnormal MRI with olivary pseudo hypertrophy. This is clearly classified in combined tremor syndrome, in tremor syndromes with prominent additional signs. So this is completely different from the idiopathic palatal tremor. And this is associated with focal lesion in the Guillain-Barré triangle. And here you can see the etiology of the palatal, the symptomatic palatal tremor of this lady, which is Alexander disease, which is easily recognized by this very, very thin spinal cord and medulla oblongata. And finally, you have the functional tremors, the somatophone tremor, which is characterized by distractibility, the very specific phenomenon of frequency entrainment, or you can also observe a less specific phenomenon, which is the antagonistic muscle coactivation. So you can suspect this kind of tremor when you observe inconsistency of symptoms, when you got a sudden onset of symptoms, when the features, the tremor features are fluctuating over the consultation, or when you have some interruption of tremor during the weekend, for example, and then on Monday it starts again. So I'm not going to comment further comment on this kind of tremor again. This is just to show you that this is in the 6th part of the classification. And of course, you have also another part of or indeterminate tremor. Tremor you cannot classify in any part of this classification. So in conclusion, the proposed classification scheme was designed primarily to facilitate the clarification of idiopathic tremor syndromes and the discovery of their etiologies. Clinicians and researchers are encouraged to use and test the new classification scheme, and the incorporation of the new terminology into clinical rating scales, clinical trials, and other research is also encouraged. And the classification of tremors will change with the discovery of new and more accurate tremor syndromes, leading to and stemming from a better understanding of their pathophysiology and etiology. Thank you for your attention.